This is a structure that makes that invisible thinking that we're doing visible. So the routine is basically look, listen, trend, check, act. Prior to walking into the room, they already know we're going to look, listen, trend, check, act. They know exactly what they're going to do when they walk in the room, and then we're going to debrief for 60 seconds as soon as we get out of the room.
What happens in the first 5 minutes inside a patient's room can shape an entire clinical day. Learn how a simple but powerful routine can unlock student thinking. Welcome to Lippincott Spark, Illuminating Nursing Education, the podcast that fuels teaching, innovation, and leadership. I'm Dr. Kelly Dries. Each episode, we spotlight bold ideas, expert voices, and practical strategies to help you teach smarter, lead stronger, and stay inspired. Let's spark new thinking and dive into today's episode. Clinical judgment doesn't happen in a vacuum. It happens with real patients and real pressure. Research consistently shows that new nurses struggle most not with skills, but with thinking in the moment. Today, we're diving into how faculty can intentionally shape those moments of thinking right at the bedside to help students notice what matters, make sense of complexity, and act with confidence. Today, I'm joined by Dr. Dana Shart, nationally recognized nurse educator, former University of Wisconsin-Madison faculty member, and now an integration nurse educator with Wolters Kluwer. With more than 20 years of experience across nursing education, Dana is known for helping faculty turn complex theory into practical strategies that strengthen clinical judgment. She's here to talk about using brief, intentional moments to turn everyday clinical encounters into meaningful learning. Welcome, Dana.
Thank you, Kelly. I'm really honored to be here, and I'm very excited for our conversation today. Having taught clinical for 23 years, I'm very passionate about clinical teaching and really supporting faculty and strengthening how we teach clinically, especially in today's environment, which we know is very high acuity and fast paced. So it's a topic I really feel very deeply passionate about, and I'm grateful for this chance to share and learn together. So
absolutely.
Thank you.
So let's start off by setting the stage for what students experience when they walk into the clinical unit. So when they arrive, and I know my first clinical, I walked in with kind of deer in the headlights. I didn't know what to expect. Everything changes. So what specific factors make it difficult for them to notice cues, think clearly, and use clinical judgment in the clinical?
That's a great question. And yes, I remember the deer in the headlight feeling also. So I think there's many factors at play here. So I think first there's just a cognitive overload. It just hits immediately. The units are busy. There's alarms, interruption. There's an unfamiliar routine. I've even had students that have not been in the hospital setting say that the smell actually bothers them because they're, we're used to that smell. I don't even smell it anymore, but it was, causing them some nausea. So I think students just process everything is equally important. And so they don't know what matters first. So they have that difficulty kind of filtering cues from kind of all that noise that's occurring. I also think that students really believe that success equals finishing a checklist. So that clinical judgment kind of takes a backseat to like checking the box, that task completion, need to do my assessment, take them to the bathroom, that kind of thing. And then I think just kind of those cognitive mental models. Students don't recognize patterns yet, and they see those isolated data points instead of meaningful connections. So again, that's where we're going to come in and support that thinking. Lastly, I just want to make note that students have fear. Like you were saying, deer in the headlights. Students have fear. It shuts down their thinking. They have a fear of being wrong, fear of harming a patient. And so they may hesitate to speak up or commit to a decision. So it really is not a motivation issue. It's just a novice cognition issue. So our job really as faculty is to simplify and break down that thinking. And I know you like this term, metacognition, thinking about thinking.
What are the early signs faculty might notice that a student is cognitively overloaded? You see that fear, like you said. What's a clue that faculty might see?
So yeah, they many times students don't know where to start, right? They'll come in and they'll just kind of pause and freeze, and maybe they'll start doing random tasks instead of like, focusing on, okay, I'm gonna scan the environment. I'm gonna, kind of check these different things. So I think maybe they'll forget to wash their hands and they'll go pick up some laundry or go into the bathroom and check something, so just kind of a random task because they don't know where to start.
And I think it starts right when they walk into that room and they, like you said, slip into that task mode and kind of overlook important cues. So what are the most common things students miss in the first kind of bedside minutes? They walk in and, how can instructors use that brief window to teach stronger clinical judgment?
So I think students will walk in and, like we were talking about, they treat every cue as equally urgent. And walking in, students don't know to scan before they assess. So they might miss that overall appearance of the patient, their work of breathing, skin color, positioning, equipment, like what I would like to call situational awareness. Um, they may not recognize what's normal for that patient. We know that patients aren't always textbook, so they don't know what their baseline is versus a change. And I think what we can do is use that consistent language with our coaching. Get the students, I always say, get them in a rhythm and routine. If they know what the expectation is, that before we walk in this room, we're going to do A, B, and C, they have a plan and it's consistent throughout our whole clinical rotation. And then just letting students know the focus is on thinking, not perfection. So the goal is this is a starting point. It's not for you to have a flawless assessment, right? We want to really focus on your thinking.
Dana, clinical time moves super fast. We know that, and faculty can often feel very stretched and overwhelm themselves. So what are realistic ways faculty can teach noticing and interpreting and responding on a busy unit, kind of using moments they already have? And how long do these moments really need to be effective?
Yeah, so just to kind of set the stage for that. So when we're looking at our nursing research, that harm signals time sensitive. So failure to recognize, failure to rescue in research is well documented. From the window from the patient declining to action is narrow. And it's often missed without that real-time cognition and escalation. And these are skills that are just perfect for in-the-moment coaching, obviously keeping patient safety prioritized. So that kind of frequent, brief, deliberate practice with repetition and that immediate feedback that we can give. And when I mean brief, it can be 1 to 5 minutes. So I'm circulating among all 8 of my students, at a very quick pace. Now, sometimes, of course, I'm making my notes and saying, I'm going to come back to you because I need to get pulled to something else. But I'm always going back to give that feedback. But that in the moment coaching, like I said, it could be at a doorway, bedside, workstation, conversations, kind of keeping HIPAA in mind, keeping those micro strategies, and then asking those thinking questions at the bedside. So what's your top concern and what will you do first and why? Add that why. And then normalize uncertainty. So telling those students, you don't need to know all the answers. I don't know all the answers, but I need you to know where to go to look for those answers that are evidence-based. And then my biggest thing is avoid rescuing too soon because I am very difficult. I want to give the answer.
So easy to do.
Oh my gosh, so easy, right? So I put my hands in my pocket as a reminder that it is okay for the student to be productively challenged. And so by keeping my hands in my pocket, I'm telling myself, I don't have to answer for the student. Oh, and then one other thing, Kelly, too, is that, oh my gosh, staff nurses, they are fantastic and they are brilliant and they're so knowledgeable about their patients. And then encouraging those staff nurses to say to students, what do you think is going on here? So, encouraging that staff partnership is really beneficial.
And I like how you said before, it's about having that great situational awareness and scanning the room. And I think of like Sherlock Holmes, like you're the investigator. What are you noticing? What are the cues? What's different? And then trying to identify what are those key priorities and letting that students really dig in. And like you said, to be challenged, and he who does the work does the learning, right? So they need to be able to be resourceful and find those resources and ask questions and dig into their materials to find that answer and to be able to retrieve that, to be able to best take care of that patient. So, I think about structure can be kind of the difference between chaos and clarity. I've heard you talk about kind of faculty-led micro strategies, these little things that they can do, like the first 5-minute routine. What is that, right? What does that mean, the first 5 minutes routine? And, what does it look like in action? And how does it really support student thinking without adding more work for instructors?
So the first 5-minute routine is basically that situational awareness that we're talking about. So as nurses, we go in and we are scanning and prioritizing automatically. This is a structure that makes that invisible thinking that we're doing visible. So the routine is basically look, listen, trend, check, act. So the look is that cues and safety, situational awareness. So it's airway, breathing, circulation, IV drained lines, environment, and then start teaching those students, what is your gut instinct? Does something not feel right? So 60 seconds, not even talking to the patient. Next, listen. What matters most to your patient right now? Is it pain, nausea? Are they concerned because family members coming in? Trend. What is one key change since the last shift? Is it a medication order, lab, assessment? Checking one critical body system. So if they're in for pneumonia, we're going to still do that head to toe assessment, but we're going to focus on respiratory. And then act. What is one purposeful nursing intervention that you can do right now? So walking in, prior to walking into the room, they already know we're going to look, listen, trend, check, act. That is what we're going to do. They know exactly what they're going to do when they walk in the room. And then we're going to debrief for 60 seconds as soon as we get out of the room. So easy, no paperwork, no grading, immediate feedback. Mm-hmm.
Yeah, that's great. Great strategy, a little micro strategy. So just wondering how you introduce this strategy to students at the beginning of the term or the semester. How do you present this to them? Like, this is going to be the expectation. And do you bring that into the debrief after clinicals?
Mm-hmm. Yeah, that's excellent. So with anything that I introduce it before we even go to the clinical floor. So everything multiple times, right? Because anxiety is high. So we're going to repeat multiple times. And then I have every student carry a notebook, a pocket notebook. And I say, take your notes. It's just going to be like a nurse with a brain sheet, but you're going to have a pocket notebook because I'm going to ask you clinical judgment questions. And you're going to say, I don't know it, but I'm going to go look it up and get back to you. And yes, like you said, debriefing post-conference is really important. Oftentimes when I'm doing many of the micro strategies, I will pull in at least one more student so that you have two learning, and then we can, again, debrief together, but debrief in post-conference.
Great strategy. So something a lot of faculty may not be doing that might help with bringing it all together. So once the student kind of begins to notice cues and they start to make meaning of what they find, how do strategies like cue clustering and clinical judgment huddles? Well, first of all, what are those, right? And how do those strategies connect the dots and kind of hopefully reduce that cognitive overload and move the student from observation to purposeful action? Because we want them to take action then, right?
Exactly. So a clinical judgment huddle to me is just a 2 to 3 minute faculty-led thinking pause that you can do at the bedside, doorway, workstation, again with HIPAA. But it is supporting students to think like a nurse. And I basically consider it a working care plan. Okay. It's all verbal. So it's just 5-step simple structure that they know ahead of time and they can keep their pocket notebook to look. But identifying the most important cue that has occurred within the last 1 or 2 hours, stating the top clinical concern in one clear sentence. So we're hearing what they're saying, choosing one priority nursing action, explaining their why, and then predicting one potential complication and what they're going to assess and look for and what they would do. So basically, it's kind of that combination of a working care plan, but it's teaching the students how to recognize, prioritize, act, justify their thinking, and anticipate. So students are explaining their thinking, not looking at tasks. So it's like you were saying, it creates structure and kind of what can be chaos in those days.
Yeah, you want that structure. And I think it helps the faculty member also kind of manage those 8 students that are, all over the floor, and they could be on different floors as well. So what does that effective kind of time efficient huddle look like in terms of timing with each student? Because I'm thinking if I'm trying to manage all of these students, how much time again are you spending with each of them and then jumping to the next person in that huddle?
Yeah, the first thing I'm going to always preach, get your students in a rhythm and routine from day one. So because it's going to decrease their anxiety. So they know that they're going to come in and do their chart review, and then they're going to make their timeline. Then they're going to get their SBAR shift change report. Then they're going to come in and check with me, and they're going to do this, this, and this, right? Because I still have to make my timeline. They have a very structured routine. So then as we go, kind of depending on where we're at in our week rotation, I will intentionally make my rounds at least a minimum of every hour to do some kind of clinical judgment in addition to everything else that we're doing, right? We're observing assessments, starting the IV, whatever we may be doing. But I'm very intentional, and I'm spending 2 to 5 minutes. And then I'll come back and say, okay, I'm going to debrief with you, but it's not going to be right at this moment. I'll come back in, 20 minutes or whatever. I hear sometimes faculty saying, well, the floor is slow or they don't have anything to do. That's a never in my book, right? There's always some learning to do. And I think if you structure it, and again, I make my timeline, so I know exactly where I'm going to be. And there's always timelines we know we're working with patients, right? They're going to have to adjust and be variable, but I try to make that intentional rotation with my students in addition to everything that I'm doing. So I think those brief micro strategies really can be beneficial for getting away from the task of I need to give a bed bath, start an IV, put a Foley in, do an assessment, right, to the why behind everything we're doing.
And I think about these strategies that they don't just impact a single clinical day, right? It's just not one and done. I think of these strategies that impact and shape professional identity. Like you said, they're learning to think like a nurse, but also become that nurse. And from your experience, how does consistent, intentional teaching of clinical judgment kind of change the ways students see themselves as developing nurses?
Yeah, that's a really good question because we do want to develop them as nurses. So I think students really start gaining confidence. They're able to speak up sooner with more clarity. And they are shifting their identity to that professional nurse, that I'm thinking like a nurse. I'm not doing that checklist task anymore. So they're starting to see the change. I mean, often students come in, and sometimes I'll just poll students just randomly to say, hey, what percent do you think nurses pass medication? And it could be like 80, 85%. And I'm like, oh, that's really interesting because that's probably like 2% of our role, right? But they don't know what it is. So, teaching them this is what nursing is. It's thinking like that nurse, which is invisible. And then tolerating that uncertainty better. So what I mean by that is that students have a less fear of being wrong, and they're more willing to start reasoning out loud because you're doing this consistently and there's not like, a black mark. This is not graded. It is really to support your learning. And then as we talked about, they're not doing that fewer random tasks. They're coming into the patient room with a purpose, with intention. I think what's really important is that students know that they don't have to know everything, but they need to know where their resources are, that evidence-based resources to look. So it really does improve not only the students' thinking, but it also improves patient safety.
Yeah, I'm not sure if you have any examples, but I think of a student that I had worked with. You can actually see from the start of clinical to the end, that you see that shift in student confidence and kind of their language over time, the way that they look at things and assess things, and the words that they're using, and the I'll say assertiveness, or more so advocacy for that patient. And do you have any examples of that you've really seen a student grow in that way?
Yeah. So I had a student that was a senior student. I think it was their last semester. This patient was going to go home. The patient was in the bathroom and just wasn't feeling well, but the patient really couldn't verbalize anything. The student did the right thing. Put the call light on. The student got the patient in the bed. The first thing that she did was take a blood pressure, which was very low. Came and got me and everything, and just kind of went with like her gut that even though this patient was supposed to go home, she was on target, and it ended up that the patient was internally bleeding.
Oh, wow. Okay.
Yeah, they took her to immediate surgery, and I like always, anytime I see her, which sometimes I'll see her at Target or something, I'm like, you're right.
So it's that proud moment, right? It's that proud moment, like the light bulb went on.
It went on, yes. And you see that so much. I mean, it gives me tingles even now talking about it, because I'm so proud of the students. They work so hard, and they are very much challenged, and they're coming away just really with better confidence and really breaking down that thinking. So yeah, it's very joyous, I think, as faculty to see that.
Absolutely. Well, and you're able to provide as an instructor that psychological safety. So like you said, that they may struggle, they are challenged by what they need to do, but they find the resources. And then all of a sudden you see that light bulb go on, and that you celebrate their wins, celebrate the things, and how far they've come. So I think that is definitely a joy of being a nurse educator as well. So Dana, as we wrap up, I'd love to hear kind of your spark. Each of the episodes, we like to end with the spark. So kind of a pearl of wisdom or a key takeaway you want nurse educators to kind of carry with them as they head into their next clinical day.
The one thing I'd like to say is that every missed cue has a patient attached to it. So when faculty pause students and ask that one intentional question, what are you most concerned about for this patient right now? We slow down that harm and speed up nursing thinking. So those very small moments at the bedside really shape students, how they advocate, escalate, and ultimately keep the patient safe. But teaching clinical judgment in real time in the clinical setting really supports building the better nurse, but it also improves patient outcomes. So every miscue has a patient attached to it.
Thank you, Dana, for sharing such practical, powerful strategies for unlocking clinical judgment in real patient care. Today, we explored how brief, intentional teaching moments, micro-strategies, and structured reflection can truly transform clinical chaos into clarity. Thanks again, Dana.
Thank you, Kelly.
Thanks for listening to Lippincott Spark. Be sure to subscribe, share with a colleague, and leave us a 5-star review. You'll find links below to learn more about Lippincott nursing products and services. Until next time, keep learning, keep leading, and keep sparking innovation in nursing education.